Hi, my name is Christy Alexander. I'm with the American Academy of Family Physicians, and I was project specialist for the Office Champions Project. The Office Champions Project is a quality improvement tobacco cessation project that was for federally qualified healthcare centers. And Family Health Centers of Georgia was one of 22 federally qualified healthcare centers that was selected to be a part of the Office Champions Project. Okay. Family Health Centers of Georgia, I worked with them for a span of 13 months, and I had the pleasure to work with Dr. Jacobs, Dr. Theresa Jacobs, and Ms. Niambi Lavender. And during that experience, I can tell you that both of them are superstar champions in tobacco cessation. They have had excellent health outcomes. They are an example of what strong leadership can do to really transform healthcare. And they have really worked hard to integrate tobacco cessation into their practices, With that being said, I would like to introduce Ms. Niambi Lavender first, and she will be telling you about the Office Champions Project and give you a snapshot of what the tobacco cessation program for Family Health Centers of Georgia.
Good afternoon. As a disclosure, the American Academy of Family Physicians, AAFP, Office Champions Tobacco Cessation, Federally Qualified Health Centers project was founded by Pfizer Incorporation, collaborated with the Smoking Cessation Leadership Center. The AAFP Office Champion Project has been implemented in 120 practices, including family medicine practices, residency programs, and FQHCs. Office Champions began with the 2011 Office Champions Tobacco Cessation Pilot Project and the Office Champions Tobacco Cessation National Dissemination Project in 2012. The AAFP Office Champions Tobacco Cessation Project. The AAFP recruited FQHCs to participate in the Office Champions Tobacco Cessation Project. An FQHC is a nonprofit, private, or public entity that serves medically underserved populations in the area. In 2013, the AAFP recruited FQHCs to participate in the Office Champions Project. The 13-month project goals were to support a tobacco-free culture, increase the number of patients asked about tobacco status, and increase tobacco cessation assistance documentation. What is an Office Champion? Our Office Champion is a team-focused quality improvement model that incorporates practical, proven strategies. It develops an implementation plan, provides training and improves staff collaboration, initiates system changes, increase patient engagement, and evaluate results by chart reviews and surveys. AAFP tobacco cessation resources were the 1-800-QUIT-NOW cards. You want to quit smoking, the Quit Now guides to help you stop smoking, and Quit Now pens. In addition to resources offered as seen above, tobacco cessation assistance was documented that included motivational interviewing, group visits, and offering evidence-based nicotine replacement therapy medication. The burden of tobacco use. The annual burden of smoking mortality in the U.S. is currently estimated to be 480,000 million more are living with smoking-related diseases. The picture above is Terry Hall, one of the people featured in the CDC's TIP campaign from former smokers and campaign. She died at 53 from cancer that she fought for 13 years. She inspired many smokers to quit with her videos by describing how her grandchildren never heard her actual voice and how smoking robbed her of her health. According to the 2014 U.S. Surgeon General report, in the last 50 years, the smoking rate has been cut in half from 43% in 1965 to 18% in 2012. Progress has been made, but we will still fall short. The references include U.S. Department of Health and Human Services, Health Consequences of Smoking, 50 Years of Progress, a report of Surgeon General in Atlanta, Georgia, the U.S. Department of Health and Human Services, Center for Disease Control and Prevention, and the National Center for Chronic Disease Prevention and Health Promotion. The National Uniform Data Center System and Office Champion Outcome. In 2011, the National UDS, it was 79.5 tobacco use screening, and 52.7% was tobacco intervention. In 2012, the National UDS tobacco use screening was 85.6% and 57.6% for tobacco intervention. And with the Office Champions in 2013, 96.1 tobacco use screening and 74.5 tobacco intervention. The chart above is a comparison of the National Uniform Data System from 2011 to 2012 and the Office Champion outcomes from the 2013 Office Champion Tobacco Cessation FQHC project that included 22 FQHC participants. Tobacco use screening, percent of patients for whom documentation demonstrates that patients were queried about their tobacco use one or more times during their most recent visit. Tobacco intervention, percent of patients that's 18 and over who were identified as users of any of all forms of tobacco who received tobacco use intervention, cessation counseling, and pharmaceutical intervention. Office Champions has success rates that are higher than the national average in the areas of both tobacco use screening and tobacco use intervention. The results of the 2013 Office Champion project are in the final report. This model has consistently shown positive health outcomes and serves as a powerful and substantial intervention. Office and physical champions working in various roles and settings provide leadership in implementing changes to create a tobacco-free culture. The AAFP's Office Champion model and team-based approach is essential to making clinic system changes. Who we are.
Give her a hand. That's the first time she ever presented. All right. So, who we are? We are FQHC right in the heart of Atlanta. We're less than a mile from Peachtree Street. So if you know Atlanta, you know Peachtree, that's the busy hub. We're less than a mile away from there. We have been in service for over 30 some odd years in the community. We see roughly 22,000 patients every single year. We do everything just about. We do medical, we do dental, we do behavioral health, we do OBGYN, we do pediatrics. You name it, if we gotta find a grant to do it, then we do it. With our behavioral health services, this says that we had an LCSW, but we also had an LAPC at the time of this particular grant to help us do counseling for our patients. And so at the time of service, we would do what they call the warm handoff to send it over to the behavioral health specialist. We start screening for depression and for tobacco use at the age of 13. It's just what we're supposed to do as FQHCs. At this conference, they've been given all these wonderful statistics, and they're absolutely right. If a patient has a mental illness, they're more likely to smoke than somebody that does not have a mental illness. What we see, because we see so many patients that over 40% are actually uninsured, most adults, unfortunately, that we see over the age of 40 have diabetes, hypertension, obesity, hyperlipidemia, and they smoke. And attached to that, many of them complain of depression, stress, and anxiety. As we see here, FQHCs across the nation, because of our patient population, over 40% of those patients actually smoke, unfortunately. And it's directly related to the health disparities, be it race, low socioeconomic status, lack of insurance, lack of education, and unemployment. The program basically, they trained us, AAFP had us go through a training process for the office and the physician champion. Our office champion helped provide health education to the patient. She also helped develop cessation plans based on health risks, and she did one of the things I think is just essential is that she monitored their process. So this person would call them and harass them, remind them of their appointments, ask them how they're doing. I think you need that connection. If it's not an office champion, a case manager, or a health educator, but you need somebody that's going to reach out to the patients after they leave your facility. And so that's exactly what she did. The physician champion, of course, identifies the modalities, also is essential in doing that warm handoff to your LAPC or your LCSW or whoever your behavioral health professional is, and also to provide the various treatment options to the patient. You absolutely have to do this on a team approach. You have to start with administration, because if administration doesn't sign on, you can just absolutely forget this. So me being not just a family physician, but also being a vice president and the medical director, they hooked me in and said, okay, the only way we're going to do this is that you talk to your providers and let's get this thing going. So it had to be a team approach the way we did this. So we also not just the providers, but you also have to elicit your nursing staff as well, because they're part of the front line. They're the folks that ask every patient starting at 13, do you smoke? And then they click that little button in the EHR so I can run a report. Isn't that wonderful, EHR? So you have to actually do a team approach. You got to have communication. You got to remind everybody. And one of the ways I did it was we generate a provider report card. It's also part of meaningful use. And if you run it by provider, oh look, it was something else when the pediatricians found out that they got a low score in tobacco assessment. That's because the nurses weren't asking the teenagers. But when they got that little report card that showed less than 10%, it's amazing the following month how the numbers just jumped because they got their report card. So it's part of the meaningful use. And it's also part of our UBS report that she was talking about, that uniform data system report that all FQHCs across the nation have to do every single year. We have to report how many smokers we have and how many of them that you actually offered cessation to. So we have to run that report starting at age 13, believe it or not. So it's got to be a full team approach. Everybody has to sign on to this in order to make it work, and in order to, and I love this word, to have sustainability. Oh yeah, sustainability. That's a good word. All right, so it was an overall system change, meaning that we actually ingrained it into the workflow. So once funding went away, you don't want the program to go away. And so once you train your nurses, and every new nurse that come on board, this is just what you're supposed to do. And if you don't do it, when Dr. Jacobs run that report, your team is going to look really, really bad. So it is just ingrained now into the workflow. And it's something that we do every single month. Providers get a report so that they can see not only smoking cessation, but depression screening, hypertension, diabetes, immunization, lead screening. So it comes as part of their report. Our overall goal was to see if we could reduce the number of smokers by 10 or 20%, and we actually did a pretty good job of it. And so part of the implementation plan as well was to get the behavioral health specialists on board with us, the health educators, the social workers, the case managers. Also, we were blessed to have a pharmacist that had a certification in smoking cessation. And he is just running on up the hill right now with it because he's gotten Pfizer to donate some drugs for us. And so he is so excited. And we thank God for him. So because, you know, when you're trying to see 20, 25, 30 patients a day, you don't want to have a backlog of patients and while the nurse is counseling them. It's nice when you got a whole team of people that can do the counseling for you, including your pharmacist. So that worked out really, really well. So we're just excited about how the program continues. When I say health education, we have a health educator who got along with our office champion, and they formulated workshops. And the workshops are free. It's just part of what we do. So Ms. Lavender was part of that. She presented, our behavioral health counselor presented, the health educator presented, and of course you have to feed the patients. So we had little light refreshments there. It doesn't cost a whole lot. We didn't have a full spread buffet, but they got something when they came to the workshops, which were free, and they still are free. Our marketing department, we do have we don't have a lot of money, but so we don't really have a marketing department per se. And in FQHC land, you're not supposed to use the terminology marketing. You're supposed to say outreach. So we have somebody that's in charge of outreach, and we have some outreach workers, but what they did was market the program, and by putting that information throughout all of the agency, also to put it on our website, and to put it on the literature that we distribute out to the patient population. Roughly 1,100 patients were enrolled in the tobacco cessation program, and 30%, thanks to Ms. Lavender and all her heroic efforts here, actually reduced cigarette intake to less than 5 per day, and 20% of those patients no longer smoke, which I think is just phenomenal. Just absolute hats off to you. Just phenomenal. So we're really excited about those results. Of course, there are challenges in any program that you do. We had some nurses that felt like that was the provider's job to ask about tobacco. And so until we got it ingrained in their head, it's a team approach and everybody has to participate in this. So you want your team to look good. It's nice to have a psychiatrist on board as well, because again, if you're identifying behavior or mental illness, it's nice if you had a psychiatrist on board. For this particular program, we didn't have a psychiatrist that was in-house, but we were able to refer some of them out. Because remember, I also told you that 13 and up, we did depression screens, and in primary care, many of you know, 20 to 30% of folks are depressed. And you miss it if you don't screen for it. And so it's nice if you got a behavioral health counselor on board, and then if you don't have a psychiatrist right there, if you have somebody that you can refer them to, and we did, it works out really well. It's nice though if you can have it integrated and have it right there on site. It makes it even better. Prior authorizations, which was just a headache, Bupropion, you can write it just like that, and most insurance companies will pay for it. But when you do the Chantix, unfortunately, that is not first tier at all. And so Ms. Lavender had to do a lot of phone calls, and pretty successful with many of them. But we had to also look at, for those insurance companies that declined it, we had to find other modalities for that particular patient, unfortunately. When you're dealing with a population where over 40% of them are uninsured, there's just everyday stressors. It just is. Because if they don't have insurance, you better believe that's not the only problem that they have. So there are other everyday life stressors, because they don't have a job, or they've got a kid that is in trouble, or they've got other health challenges besides smoking cigarettes. And so when you're trying to decide whether or not you're going to get your long-acting insulin that costs $100-some odd, to whether or not you're going to get something for your smoking cessation, you're going to probably choose the insulin over anything else. And if there's a choice between paying your rent and buying your medications, then you're going to pay your rent and not purchase your medications. And so as an FQHC, we had to kind of be somewhat inventive in trying to help these patients get their medications. Pfizer allowed us to participate in the shared care program, so sometimes we were able to get at least the Chantix for some of the patients. But again, it was a barrier and it was an obstacle for us to figure out how to hop over. successes, and we were able to ingrain this particular program into the actual workflow. And so it is still, even though the grant is gone, it is still a sustainable program. We've been able to get a lot of donated medications now through Pfizer, which is great. And so we're able to get these patients on medication if that's the desired modality of cessation. So we're doing a pretty good job, and I'm just really, really excited and grateful for AAFP and for Pfizer for funding the program and helping us to get this ingrained into our workflow. Our UBS report is looking real good in this particular area, because out of the smokers that we have, which was roughly about 2,200 smokers that identified themselves, and I should say that identified themselves as smoking tobacco. You have to say that, because, and just a little side break, we're right in the middle of the AU Center, which is a huge historical black college setting. Georgia Tech, Georgia State, SCAG is there now, and we also have Atlanta Metropolitan University. So we got this huge university complex that we are within 10 miles of. So those are the hookahs and the blunt smokers there, okay? Young adults and teenagers, that's what they do, not necessarily cigarette smokers. Then we got our main center where we primarily see those that are over 40 with chronic illnesses. They're smokers. And then we have 2 integrated facilities with behavioral health, and over 50% of those folks actually smoke. So we've got 3 separate groups of patient populations that we deal with, and all of them we're looking at making sure that they stop smoking whatever it is that they're smoking. I have to say it like that. All right, we're real pleased as punch to say that we're not only certified as a patient-centered medical home through Joint Commission, but we're also certified through NCQA Level 3, and we're just, woohoo, yes, we just got the notification 2 weeks ago. Yay! So, and hypertension and obesity, hypertension, diabetes were our 2 chronic illnesses, and tobacco was our behavioral health modality that we had to track. And so we did very well in that, and they granted us or awarded us level 3. So we're real pleased with that. So the changes that we made are now, like I just said, are just integrated into the workflow. Everybody in the entire facility knows that we are tracking tobacco use and tracking tobacco cessation. And we're also tracking to see how well our patients are doing. Once they decide to quit, we have to do the follow-up to make sure that they're still sustaining it. Alrighty, so did we achieve our goal? Yes, we did. Roughly 18% of them are now still not smoking, which I think is just super for the program. Doing very, very well. I'm going to ask Ms. Lavender to come up and give us that. She has a personal experience that she wants to talk about, one of the patient success stories that she wants to tell what we did during this particular program. And just before she comes up, AAFP does a Tar Wars presentation for 4th, 5th, and 6th graders, because you know if you can catch them younger, you're more likely to get them not to smoke at all. I will tell you that I do this presentation mostly with 5th graders, and in the slides, Joe Campbell, when I flashed that picture up and I asked the kids, who is this? Do you know that those kids know that that's Joe Campbell? That commercial has been off TV for over 20 years. So that means that the marketing and the advertising in our communities of cigarettes is still just rampant, and we need to do something about that. But because there's no way these kids should know that. They weren't born when that commercial came out, but they still know who Joe Campbell is. They talk about how cool he is in the 5th grade. So they're still talking about that. So we still have a lot of work to do. All right, Ms. Lavender.
Okay, success stories, I have several from a man perspective and a female perspective. Well, about 13 months ago, Dr. Jacobs, she just threw this on my desk and said, Lavender, I want you to work on this project with AAFP. Okay. And of course, I have too much stuff to do, Dr. Jacobs. And at first when I went in, honestly, I was very passive about it. Do you smoke? Yes or no. Do you want to stop smoking? Yes or no. Okay. They want to stop smoking. Okay. And then during the project, I found out that my mother-in-law was diagnosed with lung cancer. She had been a smoker ever since she was 14 years old, and she was smoking a pack of cigarettes a day for about 40 years. And when we found out she had lung cancer, she was already in stage 4. And so to watch my children and my husband go through this situation, I became more aggressive with the situation. So I turned into maybe like a lion. Okay, and so, because I knew that I could not save my mother-in-law, but I had to save somebody else's mom. So Chrissy always asked me, how did you get almost 1,200 people to stop smoking? Because I took my situation and I took it seriously and I became aggressive with it. So one of the patients that I had was a male, and he used to come in every other week and he would be smelling like tobacco. And one particular situation, he saw a female in the office and he liked her. And he said, I want to talk to her, I want to talk to her. Well, I said, a female like her don't want to talk to a guy who smells like cigarettes. And so 2 weeks later, 2 weeks later, he came back in the office and he said, Lavender, how do I smell? And I said, you smell good. He said, well, I'm ready to start the program because I have to find me a wife. So I said, okay. I said, okay. And so he stopped smoking just off of that, and that's a male. Whatever it takes. That was motivation. A woman was his motivation. The second situation was I had another patient that was similar to my mother-in-law. She had been smoking ever since she was 12. And I presented in my situation to her, and she saw me in tears because she's a coworker. And she came and she said, Lavender, I need to stop smoking because this really hurts you. And you told me about secondhand smoke, and I don't want to die, and I want to be around to raise my grandchildren. So she was put on a patch, which we found out that the patch does work. The patch is one thing that we know out of everything that works. And so we put her on the patch, and she has been, about 2 months free of cigarettes now, and she's been smoking for 40 years. So that's one of the things that we identified that really does work, the nicotine patch. So those are my success stories. I have hundreds and thousands or more, but I can't tell you. Yeah. So. Any questions or anything? Go ahead.
I was curious. I believe you said you provide OBGYN services at your facility. Have you had any success with pregnant women? And if so, how's that work?
No, that's hard.
That's not what I want to hear.
But you want me to be honest, right? I can tell you, oh yeah, we've been very successful, 67%. So no, that's hard. Now, some of them stop on their own once they find out that they're pregnant, but I can't say that's 100%. Our OBGYNs are in it with us, because they are actually employees of the facility, and so it's a question that they ask throughout the entire facility, no matter what you're coming in for, even if it's dental services. But unfortunately, I can't tell you that we've made a huge impact in our OB patients. It's those that decide to stop because they're pregnant, they're going to do it regardless of what we say, and even if we show them pictures, it still doesn't matter. Those that still want to smoke, they still smoke, unfortunately.
Yeah, I'm from a state that has almost 29% of pregnant women smoke.
Wow.
West Virginia.
Wow, yeah. Now, we do good in getting them stopping the drugs, though. That's...
Oh, well, then I need to talk about that.
Yeah, we get good with that, yeah. Because, marijuana is just so rampant that they feel like they can smoke, but once we talk to them, they'll give up the marijuana, but they won't give up the cigarettes.
My question, is Georgia a state that has opted to go with the healthcare marketplace?
No.
Oh.
My daughter's going through this right now. She's 29. and lost her job. And unfortunately, since we are a state that didn't expand the Medicaid, she's having to pay top prices for insurance because there's no help for her otherwise. And she's 29, not 26, unfortunately, so she missed all of that. If she had went to medical school like I told her to, we wouldn't be having this discussion. All right, but that's another story.
And why I brought it up, because those states that do have healthcare marketplace, of course, Maryland does. And on the application as you enroll, they ask the question, do you smoke? Are you a tobacco smoker? And if you check yes, that you are a tobacco smoker, then your premium is going to be higher.
Wow.
Than normally it would be if you are not a tobacco smoker.
Wow. So teaching a lie on the application, that's what they're doing. Okay. All right. Yes.
And do you get, as a FQHC, do you get bundle payments for all your services? I'm just wondering how, from a sustainability standpoint, how are you going to handle the cessation services?
Right. Those that are uninsured, we don't have what we call free office visits. We had to stop that years ago because we were going broke. So there is a minimum fee depending on what your income is, $40 for that office visit. And so they have to pay that. That helps defray the cost of their visit. We do get a grant that helps us, but it doesn't pay for all of their visit. The labs, we used to do the labs free, but we worked out a deal with Quest where we've got those labs grossly discounted and we get an indigent lab reimbursement basically.
Per person, do you get a bundle, like a payment for each person?
Right, well, we get there's a grant that comes down, right, through, it's a grant that comes, but it averages, I mean, it takes usually about 120, 160 bucks to see the average patient. We're only asking them for 40 bucks of that. And so the grant comes to kind of defray the cost. But of course the grant is, because we have so many uninsured patients now, I mean, when I first started, we were seeing maybe 18, 20% uninsured. It's now doubled. And the grant didn't increase, if you guys didn't hear that. Well, our grant hasn't increased. So we are still trying to do what we do on a shoestring budget. And that's why when we get little grants, you know, from Pfizer and from GE and from all those places, it helps defray the cost of the visits. That's what we use it for. Yes, ma'am.
I'm wondering whether offering tobacco cessation opportunities to this clinic staff was part of either the program or preparation for the program before you fielded the larger?
We are a lot harder on the employees. I'm just telling you now. She'll tell you that we are just, because we do have some employees that smoke, and they're not allowed to smoke right outside the building, but we see them walking over to their car in the parking lot, and when any time we see one of them, stop that. You know, we're really on them. Now, has any of them stopped? So 3 so far today, but we're a lot rougher on the employees than we are on the patients.
Did you feel like that was an important preliminary step before fielding the program, the Champion program more broadly?
Yeah, but you know, those employees, they know that smoking is not good for them, because one of my spills, and they'll tell you, I always say the #1 health problem in the United States is tobacco use. It is still the #1 health problem in these United States. And when I say that, they stop. Chickens, it can't be that bad. Yes, ma'am. Yes, sir. Yes, it is. And so we're really, really tough on employees. And so they know. They know. And one of the things I try to encourage them to, if they can, is not to smoke during work hours, because if you're not a smoker, you can smell it on the clothes and the hair and the skin. And I tell them that a patient that comes in, they know that you smoke. They know.
So how did you implement that maybe differently? I'm interested in hearing about doing that, because I think we're going to probably wind up having to do
Well, many of our employees are our patients,
Oh, okay.
and so we just do the same thing with them. And it's a requirement that they all have physicals, and they all get their physicals through us. So I'm your little provider looking at you. You know, you're not going to say, yes ma'am, yes sir. I'm going to say the exact same thing I say to the patients. I'm going to say to you because you're a patient. And you got loved ones, and you know, you go through the whole spiel with them. So when they come through for their employee physicals, they get the spiel. Many of them have hypertension and diabetes, and so when we treat them for that, they get the exact same spiel. Yes.
How often do you assess for tobacco smoking? Is it every visit?
We do. It's at every single visit. If you coming in for normal lab results, we're going to ask you your smoking status. We are. How do you catch the ones that relapse? You know, unless you ask them at every single visit. And when we do a chart audit, and if somebody didn't do it, we're telling them, hey, here's an opportunity. There's a missed opportunity. It's just like, you have to treat it like you do everything else. Immunizations for kids before the age of 3, you do it at every opportunity. If they're coming in for the cold, if they're coming in for asthma medications, you ask what their immunization status is every time they come in. So it's the same thing. It's a health issue, so you assess it at every single visit. Same with depression, at every single visit.
So, hi, I'm Robert Buchanan. I'm from the Health Resources and Services Administration. So I'm very familiar with the many demands that are on the FQHCs. And I'm just wondering how your program made the decision to prioritize tobacco cessation at every visit over, you know, the 100 other things that you need to be doing with your patients.
Well, you know, between meaningful use and, you know, there's a payment that's associated with meaningful use. And so tobacco is one of the things that you got to get credit for. And it's one of the ones we chose, or that's on the list. And so if you want that payment, you know, when you go to your providers and you tell them, look here, this is $16,000, folks. You want a raise? You better help me get this. It's also part of the HEDIS measures through the CMO groups. And so there are lots of things attached to it. There's money attached to it. And so it drives you when you're in an FQHC, where's the money? I mean, you want to do good patient care, but also can we get compensated for this? So I may not get compensated by that office visit $40, you know, but I can get compensated by the HEDIS, meaningful use, and then the insurance companies, because we're PCMH and tobacco is one of our indicators, we get paid at a higher level now because we're level 3 as opposed to no level or 1 or 2. So you got to go after the money, that's one thing, but you also want to combine that with good patient care as well. And it just is.
And also, on the nursing standpoint, it will be personal as far as that we get a relationship with our patients. And so we have a lot of patients with hypertension and also diabetic patients that want to come off of the medicines, but they smoke. And so with any hypertension patient, you have to make them understand that you're in a high risk for heart disease. And I also have my patients to this visit, don't smoke before you come to the office, and let's see what your blood pressure look like. And so I tried that on a couple patients, and for some patients that blood pressure would be normally 150 over 100, that day before they come to the office, they decide I don't want to smoke just to see what my blood pressure look like. They come into the office and they have a normal blood pressure. So showing them real things that smoking cigarettes would do, and that's on a personal level, with being personal with the patients.
Yeah, and I'll add also, because we've been in this community for a long time, we see generations of families, and it is something else to have a 45-year-old, you know, whose diabetes now is under control, who no longer smokes, the hypertension is under control, but they're crying because their mother, their grandmother, died or had that massive heart attack at 42, and they're crying because they never thought that they would get to 45. So when you have that type of, those type of stories in your community, and you took care of their grandmother, you took care of their mother, and now you're taking care of them, not to say I'm that old, but, but I've been around a good little while, but that is powerful. To let them know that, you know, come on, you know, we're trying to keep you around so you can be at that graduation for your oldest kid, so you can be around for them to get married. And we don't want you to be walking in there, you know, on that walker and you're just 45, 46, 47 years old. And so that makes an impact when you can talk to them on that particular level, because you know them and you know their family history. Yes?
Am I allowed to ask a two-part question?
Oh,
No, two different questions, actually. One, I think Ms. Lavender, what messaging works with the young people?
Oh goodness, with the young people. That's hard. It's really hard because, for one, they don't tell the truth. So they're not going to tell you that they smoke, okay? And so, with me, I'm a mother of teenagers. And so, you just have to be real with them. You just have to give them realistic expectations, realistic stories. And sometimes it don't work. And that's why the Family Health Centers of Georgia, we built what we call the teen clinic, that they can come in as a team and speak to each other. And so when you put teenagers together, because different teenagers go through different things. And like Dr. Jacob said, we work in inner city. And so in the inner city, a teenager that lives in the suburbs go through different things than a teenager that in the inner city. You have a 13-year-old who may be raising their sisters and brothers because their mom or dad has passed away, or mom or dad in the streets doing whatever. So they have to be around other teenagers to talk about issues. And we found out that teenagers talking to other teenagers, that's what helped with the teenagers. That really worked.
Absolutely, and I'll piggyback onto that, because the teen clinic is just wonderful, because they talk to each other. And then when you get an old person like me that come in there and say, what's hookah? What is that? You know? And they're, oh, Dr. Jenkins, who done told you about that? I said, well, tell me about it. Tell me about it. And when I was surprised to hear not long ago that they have the so-called tobacco-free hookah, watermelon flavor. And I said, are you kidding me? And then I heard a parent say, well, that's not dangerous like the tobacco. And I said, oh, Lord. So we got to educate parents as well. And you have to tell them. And so I let them know that, no, this is toxic as the ones with the tobacco. Carbon monoxide is still being, you know, emanated from your hookah activities. You know, we still have to talk about marijuana use in the whole 9 yards. But like Ms. Lavender said, when you get them peer upon peer, they seem to talk to each other and talk it out. And we help them reason why you need to leave these products alone, especially if they want to, because we get into, well, what do you want to be? You know, this one wants to be an NBA player, this one to be this one, and they want to be some sort of athlete. Well, you need to preserve your lungs if you're going to be out there, you know, working out, blah, 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 blah. However we can hook them in there. But it's a tough group.
And then how do you find funding like this program with AAFP and Pfizer? I mean, how are you looking, where are you looking for resources?
They talk about me real bad at the clinic, but they say if there's some money out there, Jacobs will find it. I will find it. So I'm part the AAFP. That's my organization. I'm part of that. And when I saw the release come out, ooh, let's see. You know, I heard, and since I'm in administration, I just immediately sent the request out. Oh, let's see if we can do that. So, and you know, I talk to as many folks as I possibly can to see where the funding is. And so you just get out there and you talk and you network, and I go online, be it Pfizer, AstraZeneca, whoever it is, we look to see. So we just get out there and we do a whole lot of networking to see if we can get the funding for whatever project it is.
I'd like to comment on that too. American Academy of Family Physicians, well, targeted family physicians, and sent out email blasts about different grants that were available. So definitely just checking with the American Academy of Family Physicians. We have things in the pipeline that sometimes people don't know that that's a resource as well. And also on tobacco prevention for youth, we have a Tar Wars program that targets 4th and 5th graders. Dr. Jacobs did touch on that, so that's another resource for you as well.
And I was just going to say, and I absolutely love what I do. Absolutely. I am a family physician that works at an FQHC that absolutely loves it. And so I am out there looking for money. I'm sitting at their houses when they come home from school. I go sit in their classrooms. I do whatever it takes to get the job done. So I absolutely love it. And doing that, you meet a whole lot of folks who know other resources out there. And once I get it and hear it, I go ahead and look it up. And if it's something we can do, then we do it. All right. Yes?
Just to add to the answer on how you find funding, that's the question I get asked more frequently than any other question. I'm a SAMHSA Regional Administrator in Region 3, which includes West Virginia, DC, Delaware, Pennsylvania, and Maryland. And Dr. McKenna, who just spoke from HRSA, is one of my partners in crime there. And Dr. Paxman, who facilitated the first panel this morning. We're all there together. We all have tobacco in our portfolios. All of our organizations have grants that have tobacco-related aspects to them. So the best way is to have a dedicated person who's really going to focus on that, not to hope you have time as an additional duty after hours. But grants.gov will show you, you can go in there and put any keyword and see what's out there that's current right now. And you can see lots of information about grants to familiarize yourself with where things are, different types of grants are located. You can also go to the websites of any of our organizations, SAMHSA.gov, HRSA.gov, look for the map with grants, and you can just Google grants and the name of the organization, HRSA, SAMHSA, Office of Women's Health, Office of the Assistant Secretary for Health, and a map, it'll bring you to a map, at least on the SAMHSA page. You click on the state and it'll show you all of the opportunities that are currently being paid for in your state, and it gives you an idea how to navigate. So those are just a few. Grants.gov is your best key. You can sign up for blasts through all of these different federal organizations, not just HHS, but it's really a full-time job to stay ahead of all of them, I think. So I don't know if that was all known by everybody in here, but I thought I should take a moment.
And I will say that we are actually in partnership with the Cobb Douglas Service Board, where we are the primary care providers in 2 behavioral health facilities, and that is as a result of a SAMHSA grant. They also have a tobacco cessation grant, so it's going to be real interesting to see what that data looks like once we get to the end of that. Yes?
Another question regarding cessation versus reduction. One of the things I'm learning is, if you only, particularly trying to intervene with the pregnant women and you're hoping to improve the birth outcome, so if she's not willing to quit, the conversation stops. So we're looking at, well, what can you do to keep her engaged, possibly with the goal of abstinence, obviously, but to reduce. I mean, do you do anything to sort of encourage them to try to cut back?
Of course, because one of the other UDS measures that we have to report on are birth outcomes. The trimester of entry, and also how much did that baby weigh. And we're compared with all of the other community health centers across the nation. And one of the things, so we're, our OB guys are very much aware that it affects our outcomes. And so they have a nice little program where they talk to the patient on a regular basis, but we're just getting ready to go into a program called Centering Pregnancy, and that's to get those, and we're targeting the group that we have the most problems with, and that's those teenagers. and the adolescents and the young adults. And so, and in centering pregnancy, they get a group of women that are pregnant about the same trimester, and they do group visits. And in the group visits, you do a lot of education, and you hope that they will encourage each other to do what they're supposed to do. And smoking, drug use, and the whole 9 yards is part of the curriculum. So we'll see how it works out, because it's that one group that we get the low birth weights for the most part. Any other questions? Well, thank you. You guys have been great.